wanted to talk about a specific test that we do a lot here at Markham Fertility and other fertility clinics as well, called something called a sonohysterogram. Sometimes we also call it an SHG, sometimes it also gets called a sono for short because it is kind of a long name. The sonohysterogram is a test that we do as part of the initial workup for somebody who is looking to get pregnant. So what I mean is that if somebody is thinking about freezing their eggs, I don't order it.
That's right.
Or if somebody is looking at using an egg donor, I don't order it. But in a situation where somebody themselves is trying to get pregnant or wants to be pregnant, then that's a test that we would order. So it's a test that we do here in the clinic, just over at Care Imaging on the other side. And it's a bit of a team effort, I guess, between one of the physicians here, so one of the gynecologists, and the ultrasound department. We'll have you come in, usually we do it in the afternoons. We use a little catheter that we put in through the cervix with a speculum exam. And so a speculum is that thing that goes in the vagina to allow us to see the cervix, the medical instrument that we use. Sometimes they're metal, sometimes they're plastic. We use metal, which is actually more comfortable and allows us to see the cervix when we put the little catheter through the cervix. Do you want to share kind of your experience with me with the sono?
Yes, I've had a couple of sonos myself. Sometimes they're painful and sometimes they're not. We find that women who have never had a sonohysterogram tend to find it a little bit more painful, and women who've come to us after having had a child or haven't even had a pregnancy, even if unfortunately it didn't result in a child, they tend to find it less painful. So, and that has to do with the uterus already stretching through the pregnancy, that when you the sono, it's barely felt. So we can go from zero pain, where patients are literally like, you didn't even know you were there, to like a lot of pain.
Yeah.
So we do recommend that patients have Advil prior to coming in, at least 2 pills of Advil. There are some patients who, for other reasons, have a lot of difficulty with exams. That could be vaginismus, that could be a history of trauma, and then we can certainly accommodate that. Sometimes we get anesthesia, sometimes we have other medications like Ativan to help them with that. Generally, the patients are in the room with the ultrasonographer and the gynecologist, and partners are not in the room, but again, there are patients who request the partners to be in the room, and we certainly accommodate that as well. So what we're looking for in a sono is 2 things. We want to look inside the cavity of the uterus, and we also want to look at the fallopian tubes. Now, we aren't always looking at the fallopian tubes. So let's say we're doing a sono prior to an embryo transfer, then we don't need to see the fallopian tubes because the fallopian tubes are not part of the embryo transfer procedure. So if we're seeing somebody with primary infertility or secondary infertility, and we're looking at the big picture and we're considering IUI or IVF, then that's an opportunity to look at the fallopian tubes. So like Dr. Wais was describing, we put a catheter through the cervix, we put some fluid in, and what that is doing is going to open up the walls of the uterus. The walls of the uterus normally are like this, and if you do an ultrasound, basically you're going to see this. It's very difficult to see what's inside. So when you do the sonohysterogram, you're able to open up the walls of the uterus so that you can see on the inside. So we're looking for polyps. Those are very, very common. We're looking for possible submucosal fibroids, or we're looking for abnormal shape of the uterus. It's called a septum. And then if the fallopian tubes are indicated, we also put contrast through the fallopian tubes to see if they're open. What are the risks of the sonohysterogram? So some of the risks are really very minimal. We do so many of them, and the complication rate is very low, but there are patients that are at high risk for infection, and that would be patients that have an ovarian cyst like endometrioma. So when we see that, we give patients prophylactic antibiotic. That means giving you an antibiotic before you actually have an infection to prevent an infection, and it usually does prevent an infection, but theoretically there is still a risk of infection, so we advise all patients, if they have pain or fever after the procedure, to contact our office.
I think it's also important to talk about what is normal after a sono, and what's not necessarily a sign of a bad outcome or a sign that something went wrong. So after a sono, we're putting a lot of fluid, so the sterile saline or the contrast, into the uterus. So it's very normal to have a lot of watery discharge after the sono. Oftentimes there'll be a little bit of blood mixed in it because we're basically kind of like we're putting the fluid in, we're going to get a little bit of endometrial tissue, like that menstrual the stuff that comes out during menstruation will also come out oftentimes. And when you have like even a drop of blood and gets mixed in with water, it can look like a lot more blood than it actually is. So that watery discharge, pinkish discharge, a little bit of bleeding is very normal. Some small blood clots can be very, very normal as well, or sort of mucousy, stringy type tissue coming out would also be very, very normal. Cramping. So I often will describe it as, so when the test is actually starting, that's often people will have the most painful cramps. As the test goes on, it tends to get a bit better. So it starts like, let's say menstrual cramps, then it will tend to get better. Over the course of the day of the sono, maybe the day after the sono, you might have some ongoing kind of mild menstrual cramps. I think is pretty fair. But you know, again, you can take more Advil and Tylenol, for instance, if you're finding that the cramping is kind of impacting your day-to-day kind of going about and doing your daily life stuff. But those things are all really, really normal. Probably normal to have that watery discharge for a couple of days, maybe a bit of bleeding, but it should sort of kind of taper off as the days go on.
Yeah. Absolutely. Another thing that's important to know is the sonohysterogram is normally done between day 5 and day 9 of the cycle. So we do this for a number of reasons. First of all, usually by that time there's no more menstrual bleeding, so we don't want that menstrual blood inside just because it can give sort of confounding information or misleading information. The other reason is we want to do this prior to ovulation. So if we were to do it in the later part of the cycle, ovulation would have happened, sex happened, and then pregnancy could potentially be happening, so we don't want to be disrupting that. So a sonohysterogram, because it's done between day 5 and day 9 of the cycle, would not interfere with couples who would want to conceive during the cycle of the sonohysterogram. So you can do a sonohysterogram in the same cycle that you're trying to conceive, and sometimes we even do sonohystograms in the same cycle as an IUI, as long as you do it early on in the cycle, or in the same cycle as an embryo transfer, as long as you're doing it early on in the cycle as well. As a matter of fact, there is some studies of some evidence that suggests that a sonohysterogram have a small increase in pregnancy rate, natural conception, after a sonohysterogram over the next 3 cycles. So we do encourage everybody to try the same cycle as the sonohysterogram and the subsequent cycles after that.
A question that I get asked a lot, and I'm going to ask you, I'm going to put you on the spot. So after a sono, how long do you tell people to wait before having intercourse?
Yeah, it's a good question.
Yeah, because I don't have a good answer. That's why I'm asking you.
I would say 24 to 48 hours. It's probably uncomfortable to have intercourse on the same day as the sono.
Yeah.
So, and again, if we're doing it day 5 to day 9, like the ovulation window is not going to start until day 10 to day 16. So I think 24 to 48 hours is reasonable.
Yeah, I think that's pretty fair. I mean, we're not going in and we're not, you know, making massive changes to the cervix or anything. So I think a little bit of time, but that's more sort of for comfort.
That's right.
For the person having the sono than necessarily that having
I
sex
don't know
is
that
gonna
there is
have
a risk.
thing.
There is no risk really even if having sex on the same day as the sono.
Yeah.
And the last question is, how often do we do sonohystograms? So if there is no changes, that means there hasn't been any regular bleeding, there is no pregnancy and miscarriages in between. We normally want the sonohysterogram to be like within a year's time. So let's say you're coming from an embryo transfer and you haven't had your sonohysterogram in 2 years or 3 years, we're definitely gonna wanna repeat one. If there was a miscarriage and there is a concern for retained products, if there was a pregnancy and let's say there was a C-section or retained placenta or complications from that point of view, anytime there is irregular bleeding or mid-cycle spotting, anytime we see something abnormal on an ultrasound, those are all the reasons to repeat the sonohysterogram earlier than that time.
Another question I think that it's important to talk about is how good is a sono as a test?
That's a great question. Actually.
And I think, I would venture to say that I think it's a question that a lot of us think about as physicians, because any test we're looking at, we're always evaluating, well, how much test of the value, does this test actually have value or not? Like, is it actually answering the question that I want to answer? So I think it's an important question for any test. So with a sono, sonos are really good at looking at the inside of the cavity, right? So again, looking for those polyps, fibroids, scar tissue, the shape of the cavity, etc. That's where, you know, they really, really shine. And so they're, you know, sensitive and specific. So those are the terms that we use when we talk about tests. So that's great. When it comes to looking at the fallopian tubes, it's still a good test, not as good as for looking at the cavity. And, you know, I think a lot of it kind of, so when I'm doing a sono on, let's say, one tube, I can't see the contrast spilling out of the tube. I never say that that tube is blocked.
Correct, yes.
I'll always say, I can't prove that the tube is open.
Mm-hmm.
And so it's like, it's subtle, but what I'm trying to get across is this idea that even though, like, I can't prove that the tube is open, but it could very well still be open.
Mm-hmm.
Sometimes, you know, we just can't see things very well in ultrasound because of, you know, where the ovary is or where the tube is located, that it kind of dives deep, sort of, let's say, behind the uterus. And so the visibility is not as good, or there's lots of a really active bowel around there. It's making it difficult to sort of see where things are. Or a lot of bowel, like gas in the bowel, that sort of creates this like shadowing that kind of, yeah, it's really like you're looking in deep into the shadows, essentially.
That's right.
It makes it really, really tricky to see. And then we also know that the tubes can sometimes go into spasm because they're lined by muscle, just like, you know, you can have a spasm in like your hamstring or something like that. Your tube can go into spasm, and it's a temporary thing. But it will look as if the tube is blocked, but it doesn't necessarily mean that it is blocked.
Absolutely.
And so that's kind of the challenge. So I'm gonna put you on the spot again. So, okay, let's say a patient has a sono and the cavity looks okay, and then maybe one tube, you know, you can't prove that it's open, but, you know, they don't really have any risk factors for a blocked tube. Like, how do you counsel around that, or what do you do with that?
Yeah, exactly as you say. If one tube is open, and it basically we look at the whole picture. So let's say this couple is young, they were really hoping to do IUI, it's the right treatment for them, and doing the sono to confirm that, you know, IUI, that there is no risk factors for IUI. And if one tube is open and the other one cannot be seen, again, doesn't mean it's not blocked, but cannot be seen on sono, then I would still advise to proceed with the IUI. Number one, because how do I go about finding out if that tube really is open or closed? It's doing a laparoscopy.
Yeah.
A laparoscopy is an invasive procedure, it's a surgical procedure, there's a long waiting list. And I don't know that your return of investment is that great in going through a laparoscopy just to see if one of the two fallopian tubes is open or not, that you couldn't see at sono. We know that even if it was blocked, even if we can prove that it was blocked, one open fallopian tube can still lead to successful pregnancies with IUI from either ovary, actually. But, you know, sometimes because IUI, there's a cost as well. We might say, well, let's only do the IUI if the follicle is on the ovary that has the proven open fallopian tube, and if not, then we'll just do time intercourse. Just because of the cost of the IUI, not because we think that there is zero chance of IUI working if the follicle is in the contralateral ovary.
Yeah, and I think that's worth repeating. Even if you have your big follicle, your dominant follicle, let's say, is on this side, but this tube, we can't prove that it's open, can still get picked up by the tube on the other side, and like there's still lots of pregnancies that happen like that.
Absolutely, yeah.
And so that's something that's really, really important.
There's a question here from Crystal from Fertility Bloom. Hi, Crystal. Question for a client. How long after an ectopic can you do sono to check on the tube, and can you see from that if the tube is okay? That's a great question. So ectopic is a really good reason to do a sono prior to restarting fertility treatment as well. I would say we want to make sure the pregnancy test, like the beta ECG, is back to zero for whatever treatment the ectopic was, whether it was surgical or medical treatment. So we want to make sure the ECG is back to zero. Ideally, one menstrual cycle has taken place. And then a sonohysterogram would be a great test to look inside the cavity of the uterus, but specifically to look at the fallopian tube. And again, if we see that there is flow going through that fallopian tube, then we say the tube is open. And if there is no flow going through the fallopian tube, then it means, again, it could be that it's not open, and now there is a clinical history. It's very different from when you said there was no risk factor. Now there is a risk factor for a potential blocked fallopian tube, so that's something to be taken into consideration. Another thing that we didn't mention is the opposite. So we're saying when we don't see flow through the fallopian tube could still be open. Well, can you see flow through the fallopian tube? And the fallopian tube is essentially not functional. And that can also be a situation. So sometimes fallopian tubes can be like there is flow through, but they could be scarred down. There could be an adhesion of the fallopian tube against the wall of the uterus. They could be swollen, and even though you see flow through it, at the time of laparoscopy, which is the only way to really look at the fallopian tube, they might not be functional.
Yeah.
So that's something to consider as well. But to answer Crystal's excellent question, I would say once the HCG level is back to 0 and there is one menstrual cycle, and yes, if we see flow through a fallopian tube after the ectopic, then that's reassuring the fallopian tube is back to working.
Yeah. I always like to tell people, like, the fallopian tube is a lot more than just a pipe, right? Like, it's not just plumbing. The tube has a lot of roles in terms of helping an early pregnancy, getting the sperm and the egg together. Unfortunately, the sono is kind of like the best test we have of tube function. And so we're looking at one function of maybe like countless functions that we don't even understand fully. So it's important to know that the tube is open, but it doesn't necessarily mean that the tube is functioning normally. Or that it's doing all the things that it's supposed to do, because it's more than just a pipe.
That's right. All right. So that's a lot on sonos. We spent 20 minutes talking about the sono.
Yeah. Well, it's a really big test.
It's a really big test. And
Yeah,
everybody,
yeah.
and almost everyone that's going through fertility is going to be doing it. So
For sure.
certainly worth talking about.